welcome everybody to the Hillman Alumni Network reception. My name is Judi Haber, and I'm the interim dean of the College of Nursing, and it is my pleasure to welcome you this evening to this lovely setting in what is NYU's newest building, the Spiritual Life Center. And I think you can all feel the soothing, peaceful presence of the surroundings from the moment you walk through the doors, and it is a very special building at NYU, and we look forward to holding many wonderful events here too. But it's a special pleasure to have this Hillman reception here, because for all of us, those of you from Penn, from Beth Israel, from Lenox Hill, from NYU, this is a very special program. And whether you are an undergraduate, in an undergraduate program, as a recipient, and being a Hillman scholar, or our advanced practice, I know that having been a Hillman scholar has truly played a special part in your professional life. So we are delighted to partner with our friends at the Hillman Foundation, the Rita and Alex Hillman Foundation, to bring important discussions to the many Hillman scholars, alums, and friends. And we are really thrilled to welcome back our own alums tonight, Dr. Kim Glassman, who is the Chief Nurse Executive at NYU Medical Center and a double NYU CN alum, and Amy Berman, who is a Senior Policy Analyst at the Hartford Foundation, the John A. Hartford Foundation, who was an extraordinary member of our undergraduate nursing program, and who are here tonight to bring very unique and valuable insight to this year's topic around patient-centered care. And the two of them are really prominent experts in that area. And Amy has truly been setting the world on fire from the IOM right across the board in terms of her recent presentations and awards. And truly, patient-centered care represents the heart and soul of our profession and is something that has been a guiding light for all of us in our short or longer careers. And we have some people here this evening who've had long-standing careers, like myself. And as an advanced practice psychiatric nurse, certainly the nurse-patient relationship, Hildegard Peplau, and others have truly been the guiding light for the foundation of my own nursing practice, and certainly pervades every important aspect. There are many people who do say it's all about the relationship and it's all about the patient, and we are there to facilitate that process. So the Hillman Foundation, and I love the story about how the Hillman Foundation and its support of the nursing profession was launched over 20 years ago, and has generously supported NYU nursing students since 1989. And NYU CN alone has had almost 300 Hillman scholars to our credit. 292 to be exact, in our 23-year partnership. And combined with students from Penn, Lenox Hill, and Beth Israel, it is likely that anybody visiting a New York City hospital will have had a chance to be cared for by a Hillman nurse scholar. And that is truly an extraordinary experience to have had as a patient as well. NYU College of Nursing, as many of you know, has been growing by leaps and bounds for the last 6 years. Our student enrollment, since we became a college in 2005, has grown from 950 to 1,620 this year, 2011-2012 academic year. We're so impressed with the impressive increase in students applying and enrolling, and they are predominantly undergraduate students. So, these students, you all, are our hope for the future. NYU's symbol, as you know, is the torch. And we need wonderful graduates like you to whom we can pass the torch of leadership in terms of practice, education, and research. So, as our society's needs for health professionals grows, the Foundation's support for undergraduate and now graduate students, doctoral scholars, allows us to attract and retain more students who are interested in pursuing careers as registered nurses, advanced practice nurses, or as nurse scientists, all extremely important to the vibrant growth of our profession and as key solutions to advancing healthcare reform as it rolls out in the next 2 years. The increase in nursing students also requires additional faculty and researchers to prepare our nursing workforce. Right now, the average age of nurses graduating with a PhD is 45, compared to the average age of 30 for doctoral graduates from the liberal arts professions and other basic sciences. So to help combat this issue, the Hillman Foundation has partnered with prestigious universities to launch an innovative and seamless BS to doctoral studies scholarship program designed to decrease the time from baccalaureate to doctorate to about 7 years. Think of how the robustness of nursing science would grow if the average age of our doctoral graduates was 30 rather than 45. Think of that career trajectory you would all have. It's your opportunity. And we hope that you're all going to take advantage of these opportunities that you have at a point so early in your careers for many of you. The contribution of the generous sponsorship and commitment to the nursing profession by the Hillman Foundation is truly extraordinary. And it really fills me with pride every time I think about a foundation that has no original relationship to healthcare, but, so to speak, adopts the profession and spends so many years making such an unusual and significant commitment to a profession in a way that advances its professional growth. So I want to personally thank Aaron Michon and the memory of your grandma, Rita, for her foresight and her sponsorship of all the Hillman scholars who have been funded over the past 23 years. And then in following my thanks, I'd like to ask Dr. Jim Pace, who is the Associate Dean for the undergraduate program at NYU College of Nursing, to join me at the podium.
Thank you, Judi. I join with you and express our passionate appreciation to the Rita and Alex Hillman Family Foundation, whose generosity and support has helped so many students here, past and present, in terms of obtaining their goals. All the Hillman scholars that I come into contact with at the College of Nursing are so thankful for the many influences of the scholarship. And I have just 3 quotes that sort of summarize probably ideas that any one of you, the scholars here, would be able to say, if not for all of them. So let me just share with you 3 quotes. Without the generosity and enriching experiences provided by the Hillman Scholars Program, I would not be able to have been prepared for the work that I have always longed to do. The Hillman Scholarship has allowed me to fulfill my dreams and allows me a network that is very strong that will ensure success. And finally, I would not have been able to obtain my degree if not for the generosity of the Hillman family. And for that, I am so very grateful. Does that sound familiar, all of you that are here? I'm sure, very much so. As Judi indicated, we recently had the pleasure of welcoming our first cohort of Hillman scholars into the Seamless Transition to Doctoral Studies program. In November of 2011, the College of Nursing accepted 20 new Rita and Alex Hillman Foundation Seamless Scholars from a highly competitive group of 15-month accelerated baccalaureate degree students. And so we're very proud of this group, and we look forward to working with them in their academic and professional goals, and it's my pleasure to see so many of them here tonight. Hillman scholars are forever changed by the impact of this scholarship on their personal and their professional lives. They learn the intricacies of the discipline and the art and science of nursing like none other. They are truly poised and prepared to make a difference in healthcare, and it shows. The evidence is there, and we're surrounded by it in this wonderful place tonight. And now it is my pleasure to make another introduction, and that is Linda DeAndrea. Linda serves as the director of the Hillman Alumni Nursing Network, or HAN as it's called. She's the clinical coordinator for the Hillman Scholars at the University of Pennsylvania, and I see many of them so very representative of the scholars at that school as welcome. Linda received her BSN from Penn and her MSN from Penn with a focus in the Pediatric Acute Chronic Advanced Practice Nurse Program. Linda is a 2-time recipient of the Hillman Scholarship, awarded during both her undergraduate and graduate studies. Linda started out her career as a staff nurse at the New York Presbyterian Hospital, Weill Cornell Medical Center in the Pediatric Intensive Care Unit. And there she was promoted first to senior staff nurse and then to assistant nurse manager before becoming the clinical nurse specialist for all pediatrics programs in 2001. In 2003, Linda accepted a pediatric nurse practitioner position at Memorial Sloan Kettering Cancer Center with the neuroblastoma service, where she continues to practice to this day. So I'm delighted to introduce to you at this time Miss Linda DeAndrea.
Thank you, and welcome everyone to another wonderful event sponsored by the Hillman program, as well as NYU. Thank you for your support of this event and events in the past, and hopefully future events. It's a wonderful partnership, so we appreciate that very much. Thank you to all of you for coming. It's a wonderful evening and a wonderful programming. As nurses, so much of our focus is on the patient, and how often do we take on that role as the patient advocate, really assuring that the needs of that patient are met. So we're really going to delve into that position more, because we are that step, that individual that is closest to helping the patient achieve those goals. So really, hopefully you'll leave here with information that will that you can take into your day-to-day practice and thereby improving the lives of patients. Ultimately, our goal for the Hillman Alumni Nursing Network is to help you improve the lives of the patients and families that you care for, either directly or indirectly. So moving forward, a lot of our programming will focus on that. So thank you for being here tonight, and we hope to see you at future programming. You'll all see that there's an evaluation tool on your seat. If you would kindly fill it out before leaving. It's really brief, but it will help us as we plan future events. Our next event will be a day of learning, focusing on education So there'll be more details to follow about that. But really, the evaluation will help us. The next bit that will help us, and I'm just going to do a little plug for the directory. There's several copies of the directory out there. There are over 1,000 plus Hillman alums out there that consider themselves Hillmans. You'd be surprised. You could walk into, yes, for the most part, a New York City hospital, but even outside of New York City, there are Hillman scholars throughout all walks of healthcare, whether it's in managerial positions, at the bedside, in the community, and even doing work in foreign countries revolving around humanitarian efforts. So you'd be surprised where the Hillmans are, and the directory is a great way to find out. Once the foundation website is up, that information will actually be more accessible to you via the foundation website. So you'll be getting requests for updating your information. So I encourage you to stay current with us so that we can continue to include you in the activities of the network moving forward. But thank you for coming here tonight. And I will introduce Erin Michon at this point, who is the executive director of the Rita and Alex Hillman Foundation, a foundation that, as Dr. DePace already alluded to, has really been the reason many of us were able to obtain our nursing degrees, but in many ways that continues to inspire us through the network to really stay positive in our profession, as well as get that education to really make sure that we're providing the utmost in quality patient care. So, Erin, thank you to you for your continued work, and I'll take this time to bring you up.
Thanks. I have to say, just a quick note, for many of you who are new to the Hillman family, for most of our existence, we were the Alex Hillman Family Foundation, and I just want to share with you that I, too, struggle with our new name, that it's sometimes tough to remember that we're the Rita and Alex Hillman Foundation and not Family Foundation. It's still an ongoing struggle. Thank you all for being here. Patient-centered care is a concept central to many of the current conversations surrounding how we can redesign our current healthcare system. It holds the promise of realigning care around the needs, and this is somewhat controversial, the wants of patients, and of improving the quality of care while at the same time reducing costs. I think it's fair to say that most health professionals would agree that, in theory, this represents a worthy ideal, a needed change. But in practice, patient-centered care is kind of difficult to locate in the real world. Why is this? Why is it more talk than action? How can we turn the rhetoric into reality? What are the barriers? What are the challenges? What can nurses do now to incorporate greater patient-centeredness into their clinical practice? And how can they advocate for patient-centered care in their workplace? And finally, there are some fundamental questions that remain to be uniformly answered, such as, what does patient-centered care really mean anyway, and why is it important? To help us to explore these and other very timely and important questions, we're so privileged to have two very inspiring and esteemed guests, Kimberly Glassman and Amy Berman. I'm so grateful to the both of them for making the time to be here. They both had other engagements tonight, and they both really went out of their way to rearrange their schedules to make the time to speak to you. And I think that what was very exciting for the both of them was an opportunity to talk to young nurses and to students. So I'm very grateful. Kimberly Glassman is Senior Vice President of Patient Care Services and Chief Nursing Officer at NYU Langone Medical Center. She leads a nursing staff of over 2,500 professional and advanced practice nurses in 3 hospitals, ambulatory care centers, faculty, group practices, and affiliates. And I'm just exhausted even thinking about that kind of enormous responsibility. It's just, it's amazing. Dr. Glassman joined the medical center in 1978. She must have been about 10 years old at the time, judging from how she looks. She joined in 1978 as a staff nurse in critical care, where she held numerous leadership positions over the course of her clinical career. She's conducted research on the patient experience, has written chapters for textbooks and peer-reviewed journal articles. Dr. Glassman is on the board of several journals, including Applied Nursing Research, Nursing Economics, and Qualitative Health Research. She received her master's degree in nursing administration, as we learned earlier, and her doctorate in theory and research development from NYU. And she is also a graduate of the 2008, she's a 2008 graduate of the Wharton Fellows Program in Management for Nurse Executives at the University of Pennsylvania, and most recently a 2011 Robert Wood Johnson Nurse Executive Fellow. She is a remarkable combination of a lifelong student, a natural-born teacher, and an exemplary leader, and we're very privileged to have her here tonight. Thank you, Kim.
Thank you.
Amy Berman, as you heard earlier, is a senior program officer at the John A. Hartford Foundation. She heads the foundation's Integrating and Improving Services portfolio, which focuses on the development and dissemination of innovative, cost-effective models of care that improve health outcomes for older adults. For those of you that aren't familiar with the Hartford Foundation, I encourage you to visit their website and to read their blog, which is really brilliantly written. Amy is one of the contributors. Prior to that, Mrs. Berman served as Nursing Education Initiatives Director for the Hartford Institute for Geriatric Nursing at New York University College of Nursing. She also coordinated the Hartford Institute's Geriatric Nursing Research Summer Scholars Program for postdoctoral nursing researchers, and collaborated with the American Association of Colleges of Nursing to provide programs that enhance the geriatric competence of nursing educators as well as the gerontological content of curricula. Before joining the university, Ms. Berman worked in healthcare administration for 20 years. She's an NYU nursing alum, in addition to having earned a degree in healthcare administration from the University of Massachusetts. Her blog posts, I hope many of you have had the opportunity to read them. They've, over the last year and a half, her blog posts for Health Agenda, which is the Hartford Foundation blog, have really become required reading for all thought leaders, policymakers across the country who are interested in the redesign of care around the needs, values, and goals of patients. She's someone I am continually inspired by and surprised by. One of the great pleasures of the last year has been becoming her friend. We share iTunes playlists together. She's a great person, and we're so privileged to have her. Amy, would you get us started? And maybe I can invite the two of you up to start, but we'll start with Amy. As they're coming up, I might just say a word about the format tonight. My hope is that after Amy's and Kim's presentation, I'll get the discussion started, but I think that we'd love to see this as much of an open exchange. We'd love to create a real conversation. So I hope that you won't be shy about posing questions, and this is again a room where there are no stupid questions. This is a very important subject matter, and I would go so far as to say that in this space that is meant for religious purposes, this is truly a sacred subject matter. Thank you, and Amy, please share your experience with us.
Before we begin, I just want to say a very sincere thanks to Aaron and to the Alex and Rita Hillman Foundation. Aaron really understands the value of nursing, the value that they bring to health care, and the importance of patient-centered care. I think that he is remarkable for putting together this day, and I'm so thankful that everybody's come here, but I think really Aaron deserves a big round of applause. I have to. So, as many of you know, I am a nurse. I'm an NYU alum. I also work at a very large healthcare foundation, and my focus has been around healthcare redesign, all around care of older adults, as Aaron's already mentioned. About 15 months ago, I had a sudden health event occur for myself. I'm just wondering how many in this room know about what might have happened to me? Anybody here? Okay, a few people in the room. Okay, so for those who don't know, about 15 months ago, a red spot appeared on my breast. And we all know what it means when you have some kind of a spot appear. You respond quickly, and I was no different. But this wasn't like a lump. This was a very, very different looking spot. And because it had a unique appearance, I felt that I knew what it likely was. And I had read an article in the American Journal of Nursing talking about something called inflammatory breast cancer. Inflammatory breast cancer, when it appears, it looks almost like an outbreak on the skin. And I made an immediate appointment with my primary care physician. I immediately was relayed to go get a scan and to have a biopsy of the area. Everything done as quickly as possible. Because it's not a lump, it's not the kind of thing that one can find out early and pick up by doing a breast self-examination. This is the kind of appearance that only happens, it's kind of a liquidy kind of a cancer that when it blocks the lymphatic system, that's when it appears. And when it blocks the lymphatic system, it also has spread. So typically, there are 4 stages of cancer, 1, 2, 3, and 4. This is only diagnosed at stage 3, which is far disseminated, and stage 4, the most advanced. I didn't know what my cancer was going to be. I felt that it was going to be a diagnosis of cancer, and I had the scan and I had the biopsy. And we did find out that it was, in fact, inflammatory breast cancer. But this is the story about patient-centered care and the choices that I made with this. I found out that it was stage 4. That it in fact had traveled from my breast to my lower spine, so I have bone cancer as well. Many cancers have different sites that they prefer to move to, and the bone, fortunately, is one of the better sites if you have to choose an area. Am I right, Deb? We have a renowned person in this area, in the field. Actually, many of you may be interested in this area. But bone cancer won't kill you. It can be debilitating, but the breast cancer would be the thing that is very fast-moving. And in fact, it has the worst prognosis of any kind of breast cancer. This one, 40% live to 5 years. That's the current statistics. The current statistics for breast cancer as a whole is that 87% live to 5 years. So it's a very, very different outcome. And that 87% includes inflammatory breast cancer. So if you removed inflammatory breast cancer, you actually have really good survival rates at 5 years for most breast cancer. But inflammatory breast cancer is less than 1%. It's rare. So knowing this and having done a full lit review, as I'm sure any one of you in the room would do, I knew that there weren't cures for this particular disease. Now, I say this, we have a demographic shift going on in this country. We've got a lot of older adults. We've got a very, very changing population. And for many of them, they're not dealing with cures anymore. They're dealing with ongoing situations, like me. And I'm going to tell you, I went to 2 very different oncologists. I went for a first opinion and a second opinion. And the first opinion, the person wanted to know what was I hoping to get out of this. There wasn't currently a cure. And I said, what I'd really like to do is to have kind of the Niagara Falls trajectory. By that I mean start with great quality of life, keep it for as long as possible, and then drop off the cliff. Does that sound like a good trajectory? I mean, it sounds good. The second oncologist that I went to, and this person, by the way, the first person suggested the course of treatment that I might do, but the second person said, well, I'm going to throw everything at it. I'm going to give you the most difficult course of chemotherapy. Then we will do a mastectomy. then we'll do radiation, and then we'll go back to the most difficult form of chemotherapy in the hopes that we just fight, fight, fight. Fighting sounds very encouraging, but fighting in this particular case, when it's not going to cure, the question is, what will it do for you? So again, I'm starting here with good quality of life. I'm going to end here. Which way do I want to go? Do I want my quality of life to be maintained and then go down? Or do I want to drop my quality of life today and end up at the same end point? It's a very simple way of looking at the problem. That's how I look at it. And not everyone will look at these decisions the same way. But when we talk about patient-centered care, we're really getting to what is it that's most important? What is the goal for the patient? What are they trying to do? And it may be that they want to fight the good fight. I say there are no wrong decisions. There are only informed decisions. In healthcare, we don't typically inform very well. We typically pronounce. We tell people what we're going to do. And for everyone in the room, if you've ever been involved in doing a plan of care, how much time do you spend writing that plan of care and presenting it? And talking with somebody and viewing that as the patient-centered aspect. But imagine, as people become more complex in this country, and we're dealing with people who may have very complex needs, sometimes we have to balance out what we're doing based on what they're trying to accomplish. So again, I went to two very different institutions and was given two very, very different courses of action. I knew what was important to me, and I'm very fortunate to say, I mean, I'm here on stage now, and it's, 15, 16 months later. I feel well, I work, I play, I travel, I'm happy, things are well, I get to enjoy Erin's chocolate chip cookies. Life is good. If I had done the opposite course, which many people would do, and many people would not even think that there are alternatives, they would do exactly what I talked about, drop their quality of life right off the map and continue out to the same end point. We talk about, in healthcare reform, we talk a lot about Don Berwick's mantra, we want better health, better care, lower costs. If you think about it from the choices that I've made, am I getting that? Better health, better care, lower cost? I certainly haven't negatively impacted my health. All of these things are possible. I am doing a course of treatment, just so that you know, and I'll answer any question that anybody would like. But I'm doing a low-impact version that really is focused on palliation. It's really focused on keeping quality, number one, not length of life. And actually, the research shows that I may live longer doing this approach. Mm-hmm. So my message to you is that there are things that you as nurses will need to do for your patients and also for the system that you are caring for. And you are caring for a sick system, not just sick patients. And you are going to have to look and see how can you advocate, document, support, and create better systems that really incorporate patient-centered care. And we'll talk about some of those recommendations afterwards. With that, shall I turn it over to Kim?
Okay, so I was asked to comment on patient-centered care from the perspective of a chief nurse, particularly a chief nurse at a large urban academic medical center in New York City. So the role of a chief nurse is twofold. My first role is to represent the discipline of nursing at the facilities that I work at, and in doing so, make sure that I have created an environment that enables your practice for those of you who practice nursing with us. And the practice that I would dream and hope that everybody is able to achieve is an independent and autonomous practice of your nursing, and that would reflect how you choose to interact with patients and families that you come in contact with. The other role that I have is to sit at an executive leadership table as the only nurse, the only voice of nursing, and sometimes the only woman, which has its own interesting gender dynamics that play out at those tables. And my role at that table is not so much to advocate for nursing, but to advocate for patients and to represent the voice of patients and families in the context of how we govern our particular academic medical center. The vision of NYU Langone Medical Center that I was part of creating about 5 years ago, and we worked as an executive team with a fancy visioning consulting group that helps large organizations develop visions. And we came up with a very simple vision that I think we all believe in, which is that NYU Langone Medical Center is a world-class, patient-centered, integrated academic medical center. So I'm really proud that the fights that I had at that table got patient-centered into that vision. But the interesting story behind that fight is that every discipline has a different view of what it means to be patient-centered. So I will tell you that physicians think that they are patient-centered too. They became physicians to save the world the same way that nurses did, but they save the world differently. So medical practice is different than nursing practice. In an academic medical center, medical practice is highly subspecialized. That's what we do at NYU Medical School, is we train subspecialists. And that means that our patients have multiple physicians who look at people with multiple lenses. Nurses, conversely, are the existentialists of healthcare. We look broadly at people in the context of their life and figure out how are we going to help them live with whatever condition it is that they're coping with, and how are we going to inform them about the choices that they would like to make. So there's an interesting tension at these tables when you have a group of providers who believe wholeheartedly that a particular treatment, as debilitating as it may be, is absolutely the right thing to do. And then you have a group of providers, and that would be us as nurses, who understand that it isn't about us. It's about the people who we serve. So one of our challenges as nurses, and particularly those of you who practice in hospital settings where you are part of a very dynamic team of providers, our challenge is to make sure that we are understanding what our patients in fact want. And in order to understand what they want, we have to explain what some of the options are. And often we are explaining options in the context of a medical treatment plan that perhaps, when explained, is not exactly what the patient wants. So Amy has a very compelling story of what it's like to be a nurse and now find herself on the other side of the looking glass. And I think that very often for providers, our own experience of a healthcare system, when we find ourselves as a patient receiving care, or when we have a family member in that setting, I think the tensions and the problems of our system kind of hit us smack in the face.
I'm curious, a kind of general question. and how you feel about this, both as a patient, a nurse, and as an administrator of a large hospital. Don Berwick, who you referred to earlier, talks about a debate, a kind of tension when it comes to thinking about patients' needs versus their wants. Some advocate for respect for patients' needs, but won't go as far as conferring sort of control over to a patient's wants. Where do you see that? I know that, Amy, you've used this term that you see the patient as true north. They're the guiding star, or they should be the guiding star in the delivery of care. How do you both address the challenge of achieving that kind of ideal in your various experiences? And I'll leave it open-ended.
So it's a terrific question. It's a complex question. There are people, patients. Some people don't even like the word patient, like it's taking away their power. Suddenly, they're ours. We can do things to them. And some people in the patient empowerment community prefer to use the word person. So the person who's experiencing illness, they may not want to make these decisions. I mean, that's a reality. I mean, I'd like to think probably everybody here in the room might want to make those decisions. Everybody here has a certain amount of being informed and probably being very activated around their own health already. But I think it's important that we invite people, we ask people whether or not they want to know. And if they don't want to know, who in their family or who is their friend would want to know, and kind of take people down the street of informing them. But once people are informed and they've been given different decisions, I think that we have to have the ability to respect that. You don't give people a decision that is, you don't give them an option, or you're not counseling them on options that really are so outrageous that they would be bad for you. I mean, you wouldn't send somebody down to Mexico to use peach pits, but you would use evidence-based approaches, and there's usually a range of them. And you would think about what is their goal of care. And I think the problem is the first thing we don't do is to ask what is the patient's goal. And it's very difficult to find documentation so that the team can respect and follow that true north. But the patient is the true north in healthcare. It is their body. It is their life. And there are some complex decisions that at certain times have to be made, from my perspective.
So I'll give a different perspective, just for the sake of having a good conversation. So taking the view, the large view of a sociologist, the job of healthcare providers is to get people back to work. So when you have a society, people in a society have to produce. They have to do some kind of work, whether it is physical work or intellectual work, but otherwise societies devolve. So the job of doctors and nurses is to get people back to work. And if you look at the crisis that we have in our country today, there is no money. There is no money. Now, partially there's no money because we're fighting too many wars, so we can go down that road. But there is not a lot of money for health care. And when you have scarce resources, you have to make some choices about how those resources are going to be applied. So while the nurse and the individual in me says, how does it go? Nothing about me without me, there's a broader view that healthcare leaders have to attend to, and that is, what are the choices that we are going to make? What are we going to invest in terms of technology? What are we going to buy in terms of people to provide care? So there's this overarching view of what kind of care are we going to provide. So the tension that we speak about is you've got to make people aware of what their choices are, And then you've got to accept that either they're going to make choices that you don't think are the right choices, or they're going to make the choices that you would approve of. But if it isn't about you as a provider, you might choose to let someone go to Mexico and have peach pits. And the scientist in me would say that what we know about the human body, you could barely fit on the head of a pin. So today's peach pits might turn out to be 100 years from now's great treatment. So we do things to people and we recommend treatment based on some reasonable body of science, but it's our best guess. And we never know for sure if these are going to be the right choices. So obviously that is not a conversation that I would have with my patients because I don't want to make their life more miserable than it is. But in the back of my mind, I'm always questioning, is this the right option to bring forth? And how will I explain this in a way that people can really make the best choices for them?
I know we have a question in the back.
And that's part of what we want to do is really have some conversation. So we're being purposely provocative here because we want to hear from you.
Yeah, I was just wondering what, it's kind of related to your point, what you thought about when the patient's choice kind of adds up to greater healthcare costs for, you know, in like public health insurance. Like, you know, I can't really think of a good example, but if a patient decides to keep smoking and then, you know, that's going to, you know, add up to bigger costs for all of us in the end and, you know, our children in the future, and how you feel about patient-centered care in the context of that.
So I think that that's the tension that you all are going to have to live with and help solve. So right now in our healthcare system, the rights of the individual prevail. I think that as we mature in redesigning a healthcare system in the face of no money, we are going to have to grapple with what those tensions mean. So today, people can choose to keep smoking. They can choose to follow a recommended treatment or not. And they can choose to take their own life or not. So right now, free will is what prevails. 50 years from now, as you all are sitting up here having the same lecture to a new future, you may be dealing with a very different world. So I think that I would ask you, how would you solve that problem?
I don't know. Sorry.
What?
That's okay.
Amy, did you had something to add?
Yeah, I would just add one more thing. So, of course, everything that Kim says is true, but in addition to that, if there's been research on physicians that people who are the most knowledgeable of very complex care, when they themselves are confronted with these situations, they choose the less aggressive path. There are studies that show that patients who are better informed also happen to be lower utilizers. They tend not to end up in the ICU. They tend to have less hospital admissions. They tend to focus on things that control their symptoms and pain and better manage their own health care. So the more involved, activated, and knowledgeable patients are, the better they are in terms of better health, better care, lower cost. So the research has borne that out. You're right, there is free will out there, but this really speaks to the role of nursing in terms of informing and helping people understand, you know, and articulate their own goals of care. Because when their own goals come out, more times than not, they are a better choice in general, not just for them, but also for the system at large.
Amy made an interesting point that in her visit with her first provider, the provider asked her, "What do you want out of this?" So I think that if we started all of our conversations with people with, "What do you want out of this?" That would be one way to start. But there's lots of hands here, so this is great.
I know
here?
you.
I had a really interesting experience in clinical recently, which made patient-centered care come alive for me. So I had a patient who was very sick. She had diabetes and was about to go on dialysis. And she had this stew that she was so excited about. And it had been sitting in the sun for, over a day by the time I had her as a patient. And, I wasn't sure about my microbiology, but I was pretty sure it wasn't safe to give her this stew. So I went, even though she was so excited. So I went and checked with her nurse, and I was like, "Oh, can I just throw it away?" And she said, "No, you cannot do that. You have to talk with the patient about, whether she wants to eat the stew or not." So I was surprised because this is, something that could be harmful, but I was really glad afterward to have had the discussion with the patient, talking with her about, her risk for infection and what it meant to eat the stew. But it really mattered to her to eat this because her nephew brought it to her, and her nephew is so close to her, and he's a cook, and for her to have that connection with her nephew was so important. She decided to eat the stew, and then later decided not to eat the stew. So, I didn't go home worried about her. Well, worried, but not as much as I had been if I would have been. But anyway, it was about her, own decision, and that was, a neat experience for me. And then I have one more question.
Sure.
One question. For Ms. Berman, you talked about documenting, room for documentation for goals of care. And I think that's interesting because we document sort of chief complaint. And I was wondering how that differed and what sort of space you think we should provide for room for that.
Oh, there's lots that we need to do in this area. And we really are talking about reforming healthcare delivery so that it is more patient-centered. But today, you see at the top of any chart or front and center in the electronic medical record, the name, the diagnosis, key information about the treatment plan. I will challenge any of you to find a pre-existing field that identifies patients' goals. You may write it in, you may put a note, but what that means essentially is that no one's going to dig through, in very complex, serious illness, no one is going to dig through this mountain of notes, whether it's electronic or physical paper, to be able to find what that goal is so that the team essentially can support it. So when I say the patient is the true north, the diagnosis is actually not the most important thing. It's what are you trying to accomplish for that patient? You can, there is I'll quote a physician. I hope it's not too bad to quote a physician, but William Osler was the founder of modern medicine. And he said the good physician treats the disease, the great physician treats the person who has the disease. I think nursing lives that, but I think we have systems that don't really live that. And we have to think, if you're going into informatics, if you become part of nursing administration, if you think about systems, you have to think about how to operationalize what is patient-centered care.
And I would add that it sounds like you did a great job of exemplifying patient-centered care, and bravo to your mentor who said, you can't throw the stew away. So, but think about this. Your concern and your need to express concern for your patient was to get that stew that had been sitting in the sun out of that room because you didn't want her to be harmed. But having a conversation with her, taking the time to do that, not sneakily throwing the stew away and saying, "Oh, I don't know what happened to it. It was here a minute ago," was that no. But people do, and they don't think it's lying. They think it's protecting the patient. But having that conversation brought you closer to what are those behaviors that I have to do as a professional nurse to make sure that I'm engaging the patient in that conversation. So bravo.
Janet?
I want to thank both of you, Kim and Amy, but my question is for you, Amy. First of all, thank you very much for your generosity and your courage in explaining your situation to us.
Thank you.
You did a great comparison between the two physicians, and that really made it very clear for me where your goals were and how you analyzed it. What about nurses that you came across? Could you give us some examples about experiences about what nurses did that you saw as positive? Or
I have had the most remarkable set of experiences with nurses really caring about me and whether my needs are being met, asking how I'm doing. They're not just, hooking up an IV so that my bones can be made that much stronger. They really were caring about how I was doing and making sure that my needs were being met. There are so many things that need to be handled, and the physician handles a very small piece, a very important piece, but a small piece, essentially setting a boat in motion. But from there on in, all of the rowing really is the nursing team. And it really is absolutely remarkable to see well-run, effective teams, exceptional clinical skills, people who care about how I'm doing emotionally, people who ask about my family and remember my name. I know that these things sound like small things, but when you're experiencing serious illness, for somebody to take that extra time, I don't go there very frequently. I mean, I go once a month. And in that month's time, I would think they've seen so many other faces. And I'm really treated like a human being. Exceptional skills, but I'm treated like a human being by the nursing team. And I'm just so impressed with nursing. Thank you for asking that.
In the back, and then we'll move over to the side.
I'd like to share with you a few things. I think patients, they may have the same diagnosis, but they may not have the same needs. And so from my experience, I think the most important thing is identify what's their need, knowledge need. From my study, most important thing is a lot of time they cannot make a right decision, or they have wondering they don't want to make decision because certain knowledge is really not filled in. And everyone's need is different. Everyone's knowledge needs is different. So I would say for myself, in my clinical experience, first, I want to find out what do you like to know? And based on that, I will answer you and exhaust all your questions. And from my finding, I find out patient empowered. Maybe very simple things, but if that block them, they're not going to move. They'd rather you make decision because they don't know what's the right thing to do. So that's very important. So identify patient's need, and based on that, resolve that. And from the finding, I find out patient doesn't have to stay in hospital for many days because they know how to take care of themselves. They know when I have a problem where I will be able to get help. And that kind of thing can be as simple as, if I get into problem, where should I call? And that's very simple. And it's not a stupid question, but for patient may feel that it's really not smart. So that's my experience. Find out what they want to know and help them from there. And how to save the money and in the future, very simple. If we can find out what's the most common problem, and we can develop something and let them review themselves when they are more relaxed, instead of say, you have a cancer, you're going to die, and all of a sudden you come to me, and then say, oh, whole brain is, I'm going to die. But at night, when they need a question to be answered, they can go to the place to find the answer. Thank you.
I think this also speaks to the role of patients, too. The role, is there such a thing as we talk about physicians being better physicians or nurses being better nurses, but what role do patients play in helping to actualize patient-centered care?
Well, I just want to go back to the comments that were just made. And, you said it's not just telling somebody that they're going to die. I think that's, in my situation, or, for people at the end of life, oftentimes they're actually never even told. They don't really have a good sense of kind of what their prognosis is. And whether it's end of life or just complex illness or complex choices, I think we don't do a very good job kind of owning up to where people are. We'd rather let the clock run out than really be truthful in informing people. And that is a first step in being able to activate people to be able to make choices. I mean, it's very hard to make choices if you don't know that there are choices to be made, let's be honest. I kind of think about this like, healthcare is it's something that you buy, right? We pay a lot of money for health insurance. Or if you don't have health insurance, you're paying a heck of a lot more. But you're not entitled to very much transparency in terms of understanding what's going on in your own health. People say that maybe they don't have enough time. It's a burden on the system to spend the time doing this. But, we get more open discussion when you buy a house. They actually have to give full disclosure. In serious illness, no such thing. And I think that these are basic consumer rights, and it starts there.
I think that patients, people, we live in our own bodies. So we know most about the sensations and the feelings and the hopes and the fears that we have with whatever situation that we're in our healthcare encounter. And I believe that our role as nurses is to help get inside that body of that patient and help them find the words to express what it is that they're feeling. And we can do that in a variety of ways, but that's really where we have to get. So I think the role of the patient in this, of the people that we're caring for, is to try to find a way to explain to us what their needs and wants are. But it's our job to help them find the words to express it. We don't know what it's like to live in their body. So every day we administer medications, and we know from our practice and from our reading of drug literature that a particular drug lowers blood pressure, and it's going to make someone with heart failure feel better, but we don't have heart failure. So we don't know what it's like to wake up in the morning with a blood pressure of 70, and we may be really happy because it isn't 200, but 70 may be too low and this person can't go to work because they're dizzy all day. So I think that we have to work really hard to pull out those sensations that people are feeling and dig deep to ask those questions. Because when you talk to patients about medications, often they lie. So you say, oh, you have this list of medications and you're taking this, this, and this. The very clever healthcare provider says, gee, empty your purse and let me see what's in all those little bottles. And wow, there's a little yellow pill. What do you take that for? And what's that about? So you have to take the time to really dig that out a little bit. But that is not often what we do. There was a lady over here who has had her hand up for a while.
Thank you so much for speaking with us today. The patient-centered medical home has been a way that many patients with chronic diseases have received better care and more coordinated care amongst many providers. I was thinking about how patient-centered care is now being pushed to all patients, not just those who have significant issues. Do you think that is a positive way or a better way for patients to start that conversation early about alternatives to care when something serious does occur?
So there are movements afoot that people around the country who do believe that all of these conversations about choices need to happen much earlier. And in fact, half of people at end of life are incapable of making decisions about their health care. So there certainly is a good reason why people should be having conversations with their primary care team, whether it is their nurse, their physician, if there were social work involved, whomever in the team has the ability to have these conversations, they should be occurring. But then we still have to check. I mean, right now, for most of you in the room, you're not confronting something, and if you were to confront something, you might feel differently. Mm-hmm. So we can, and even when you go through it, you may change your mind along the way. This is healthcare. We're allowed to change our minds. That's the nice thing, autonomy. It's really great. But I do believe that having these conversations early for many people is critically important, because these things will happen, and at the time that they do happen, oftentimes you are not able to make those decisions. It is not the norm to have long periods of time and to be, to live relatively well and to be able to think these things through. Usually things progress in a much more difficult pattern, and you may be compromised. So yes, the patient-centered medical home or health home, these are important opportunities for primary care to engage in these conversations. Primary care says that they're not paid to have these conversations, and they're reimbursed terribly. I mean, we may not talk about reimbursement, but they're really reimbursed for very, very small, short visits. And you can imagine these conversations really take time. So we are confounded about how to do this well, how to do this right. There's a woman named Ellen Goodman. She is a former writer for the Boston Globe, and she wrote recently in the December Harvard Business Review about the need to have the conversation, and she started the Conversation Project. And she believes that these conversations have to begin at home. Not a medical home, not a health home, but home. And they have to be with families, and families need to be witness to what people's choices are at whatever point in life they are at. And not when they're ill, but just as a routine, that this should just be normalized. I do have to say, I knew what I would do immediately when put in the situation, because these conversations had occurred in my home. My grandmother is the person who, her name was Shirley Dinnerstein, and she's in your nursing ethics textbooks, and she is the reason that we have a healthcare proxy today. So in our family, we were confronted with a very difficult situation. She had advanced Alzheimer's, and the family wanted to be able to support what we knew to be her decisions. And at that time, it was not possible. So we had to, there was a process, and that became the healthcare proxy. I can say that that is her gift to me. But it also made it very easy for me to know. I know what my mother would want to be buried in. My mother's healthy. My mother speed walks me into the ground. I mean, she's just great. But we've always had these conversations. Well, it would be great if these things were much more normalized.
How many of you have a healthcare proxy? Not enough of you. I have just an interesting quick tidbit, which is I am at the phase of life where I am dealing with elderly parents and elderly in-laws, and both my mother-in-law and father-in-law have and had heart failure. My father-in-law died this past November. And my mother-in-law, who has had chronic heart failure for a long time, is not a candidate for heart surgery, is the person that we thought would die every time she went into the hospital. And they get their care at an academic medical center in another state, in Connecticut. And there's really only one main one there. So I have had a lot of experience on the other side, but as I have run out of work in New York and traveled up Route 95 to pick up my mother-in-law to take her to the emergency room numerous times with a blood pressure of 250 over whatever, as she has put on her lipstick and she's looking really good, and the nurses in the ED at Yale are saying, Mrs. Glassman, why are you here? And then they take her blood pressure, and all of a sudden, a million people descend, and they whisk her into ICUs and all of this sort of thing. And a hospitalist or someone always comes into the room and says, do you have an advance directive? And she's like, what? And then the next step in the conversation is, well, we'll talk about that tomorrow. So we're not really good and comfortable at having these conversations. And having made many emergency room visits and witnessed this conversation, I decided that on one of the trips to take her home in the car, because I'm a nurse and I know how important these conversations are, I turned around in the car as we're whisking up 95 and I said, Ma, when the doctor said to you, do you want to be resuscitated and do you have an advance directive, do you know what he was asking you? She said, well, not really. I said, he was asking you, if you die in the hospital, do you want them to jump on your chest, bring you back to life, and stuff a bunch of tubes in you? She said, of course I don't want that. And I said, fine. Then the next time they do this, tell them you're a DNR, and that's what that means. When you die, we're not going to bring you back to life. So having this conversation in a whizzing car, in a family, my husband's family, that didn't have these conversations, so they didn't talk about this. This was a new discussion. Led us to be able to eventually get both of my in-laws on hospice at home. And then I had to negotiate a good death for my father-in-law, which I'm very proud of. But I think that Amy brings up a great point. These are conversations that you need to have tonight or tomorrow in your own families. You need to think about what are your choices. Because it just makes it so much easier if we can begin to talk about it. As a society, we're not good at talking about these things. Amy comes from an amazing family like I do. I am from a family of nurses. We have horrible dinner conversations. But I, too, know exactly what my mother and father want and how they want it. That's all discussed and negotiated ad nauseum. So important to have those conversations. Yeah.
Hi. I'm actually a psychologist. Thank you. I'm a psychologist, and I've worked in long-term care for about 15 years. And I'm really glad to hear this conversation among nurses. And I would say that my experience with nursing is some nurses are more involved in care than others. And sometimes I feel like the approach is speeding through. And even though people are well-intentioned, they can't get to spend the time with the resident patient as much as they would like to and explain things. So I'd like to make a shout out for using mental health services, because our job is to sit and talk with people.
Absolutely.
And I wonder what you see as efforts to coordinate the team and actually have somebody appointed specifically to be talking about these issues, because mostly people are doing their own silo work.
Yeah, so that's actually a great topic from my perspective, because I have had the great fortune to work with a physician named Linda Emanuel at Northwestern, who is a noted geriatrician and palliative care expert, who believes that physicians are not good at having these conversations, and that in fact it is other members of the healthcare team, social workers, psychologists, pastoral care, who need to be empowered and trained and comfortable at having these conversations. So I think that there are a number of efforts around the country, but very important to make sure that that we are engaging everyone, because you're right. Psychologists, mental health people, social workers are probably in many ways better equipped to have the conversations. the advantage that the nurse has is that they're at the bedside 24/7. So they are there in a more vulnerable moment and could help someone work through that. But there are members of our team who are much more skilled through their schooling and their practice at having those conversations. And at our particular medical center, we have palliative care teams and all of that, but as part of our interdisciplinary forum, pastoral care, social work, where we have psychology involved, are front and center at rounds every day for at least having an understanding of what the medical plan is going to be, and then can help negotiate that space between what a patient may have indicated they want versus what the team is doing. So very important. That I think, and that's a really important point, no one discipline owns patient-centeredness. The patients own patient-centeredness, and it's our job to work through whatever systems we have, and whoever touches that patient and can get through is the person who should pursue that.
I'm from the field of geriatrics, and we say geriatrics is a team sport. Mm-hmm. So I would definitely agree, but actually I would strongly agree and disagree. So the agreement side is we need people who are trained in how to have the conversation, how to support the conversation, how to document the conversation. How many people in this room have ever heard of POLST? Physician Orders for Life-Sustaining Treatment. In New York, they call it MOLST, Medical Orders for Life-Sustaining Treatment. Okay, so some people have, you've all learned about advanced directives, the Do Not Resuscitate order and the healthcare proxy. But there are other formats, including the ones that are available both in Pennsylvania and in New York, that are much more nuanced. So, for example, you could choose on this form, you could choose to go fully aggressive and document that you want everything possible done. But you could also say that you don't want to have antibiotics. And to be honest, when my quality of life goes downhill, it's not just aggressive care. When I'm really doing poorly at the end of life, it's my right to say, I don't want to treat pneumonia. What's the purpose? To extend bad life? As I said, I want that Niagara Falls trajectory. So everything that's going to be on that form is going to be for Niagara Falls trajectory. And I'm going to say no antibiotic when I don't have quality of life. Now I'm fighting for every bit of quality of life. Mm-hmm. But when it's gone, you're going to see that reflected on my form. But I would also say that, the one aspect is to have other members of the team support patient-centeredness. But there is a point, whether it's an advanced practice nurse or a physician, where you're setting up the treatment plan and you are going down a road. And we need to make sure that we are taking responsibility for that as well. And we are helping the team to bring forward the goals of the patient back to that team and to say whether or not everybody's on the same page about the destination of the bus. Are you really looking to go there? Well, maybe you're not. So there is a component for a person beyond the physician. And there is a role for the physician or advanced practice nurse. And there is a team that needs to occur. But I think the notion of incorporating spiritual and psychosocial needs is often either forgotten or under-addressed, and incredibly important.
What does it mean to be patient-centered in pediatrics then? This is kind of a random question, but it's often a population that can't actually voice what it wants, as well as the parent is often considered a patient as well.
So that's interesting, and I might defer to some of the people who are pediatric, who practice in pediatrics, but I think that it's the same parallel. So where a child is under the control of their parents, parents are your patients in pediatrics and children's services. So you're going to work through the parent and find out what they know and their goals of care. So I think it's engaging both. where you have a child who is old enough to understand and be part of those decisions. In research, there's an attestation form that we use with children who are of a certain age, 10 and older. And those of you who deal with children know that better than I do, but there's some point where it's believed that children could be part of their own decisions. So I think that the parallels are the same. And where you have, we have a big children's cancer service, so have a lot of conversations about goals of care and treatment. Luckily, children are not apoptotic and having dying cells like adults are, so they can be cured and they have great results, but you got to work through those issues with parents. And then you have the occasional issue that hits the news where parents choose to use different types of healing for their children and take them outside the medical system, and then we get courts involved. So things always get more dicey with children.
I'll actually run a parallel between pediatrics and thinking about the issues with people who have cognitive impairment. Because I think that there are issues that confound us when a person is not fully able to express, and I think we oftentimes make assumptions about what their level of knowledge is and what their goals are. And I think, even with older adults with Alzheimer's, there are oftentimes opportunities, times of day, windows of lucidity, they call them, to be able to have some conversation and understand what their goals would be. And I don't think that we should be assuming that a child doesn't have thoughts about this. So it is certainly more challenging and more complex, but I think we have to, as nurses, part of our role is to see how much we can bring forth from that individual. In the case of a child, their parent is going to be the ultimate decision maker, but we still can advocate for that patient, not just for that parent, but for that patient, and help to bring forward things that we hear, or we see, or we understand, and share them in hopes that it can be a more patient-centered care.
I have a question for some of you who practice in interdisciplinary settings, and I'm wondering, when we talk about sort of the tension between providers and patients in terms of what we believe is being patient-centered, sometimes you have a situation where there's a medical plan of care, and you as the nurse get different information from a patient that perhaps they don't want this treatment plan. So I'm just curious as to how do some of you negotiate the space where you are the lone voice on behalf of the patient, and you've got a very powerful group of physicians who are saying that this is what we need to do. So I'm just curious, how do you advocate for patients when you're the only one on the team who perhaps understands what the patient wants? Have
any of you experienced that kind of a situation where you really feel like that person?
Yes. Because you are one of the more experienced people in the room, Sumin.
Yeah, I want to say it's very important to provide all the information necessary to the patient. And it happened many times. And so I gave him all the choices and everything, advantage, disadvantage, and tell them, think about that, and you make your own decision. And that is very important. Obviously, I have all the conflicts. Later on, they come over to yell at me and whatever, but that's patient decision, was not mine. And I think all of you in the future, or maybe now, have already or will have this kind of experience. But knowledge is very important. If I provide them all the right information, evidence-based, I have nothing to be afraid of.
Right. So I raised that because Amy and I the other day were talking about this situation, which I think is in Texas, where a nurse was fired for giving a patient information.
Has everybody gotten the
that
chain
was
email that's
contrary to what the physicians felt was appropriate for the patient? Do you want to tell that story?
Oh, so there's a nurse in Texas who worked in a transplant unit. And before the patient was going to have a test related to the transplant, the night before she was supposed to educate the patient about the test. And she went to the hospital's intranet and pulled down patient information, education information, printed it out. So this was all, hospital approved material. She didn't go outside on the internet. And in speaking to the patient, she presented all of the information, including if this person was found to be a candidate for the transplant from the test, what her life would be like after the transplant. And it had said, and this is what we have been sent. Obviously we haven't read transcripts of the trial, or of the hearings that are going on around this, but the patient, according to the medical record, the physician said that the person either was going to have a transplant or go on hospice. This was a note that the doctor had written. So the nurse knew, she was fully informing the person about the test and about what kind of was going to happen down the road. And the patient said that she didn't want to go down that road, that hearing what her life would be like, her immune system would be compromised, what her life would be like on medications, and, what likely would be the outcomes of all of this. She didn't want to go down that road, and she told the nurse that she wanted to speak to somebody related to hospice. So the nurse wrote a note in the record, this is what we're told, that said, could you please have hospice speak? The patient wants to speak to hospice. What that meant was that the next day the patient did not want to have the test done, and the physician was losing his transplant patient. And this nurse now is, I don't know the status of it right now, but we hear the nurse may lose her license, or her license is in question for having written a medical order by writing down that she wanted somebody from hospice to speak to the patient. Now that was the patient's request, but apparently that's considered an order, for hospice. So I think it's all very questionable, but in this case the nurse obviously was advocating for the patient from everything that we have heard. And mind you, we don't have transcripts, but this is what we have heard. And that nurse is no longer at that hospital and may very well lose her license for advocating for an individual.
We have time for, I'd say, 2-3 additional questions. Linda.
Hi. Just towards the pediatric point. No, thank you. Since
I was hoping you would say
thank
something.
You.
Good.
Have to open up at some point.
Yes.
There is something that we refer to as assent, and although that we do require 18 is considered, age of consent, many pediatric patients are under 18. If we feel that they are cognitively and developmentally able to comprehend what's happening to them, we do need to obtain their assent when we are doing something, which can be very challenging when you're working in pediatrics. I may have a 12-year-old who says to me, I do not want to do any more chemo. Mm-hmm. And I have to take that information and discuss that, with the child, with the parent, with the team, so we can make an agreement that we can all agree on. And there are cases where, because a 13-year-old said they don't want to do anymore, we have to say to the parent, we cannot continue to give this to them when they are telling us and they understand what's happening, that they do not want to do this anymore. And we need to come to something that we can all agree upon. They're very difficult conversations, but they need to be had. And I think just the common thread that we're hearing is how we as nurses can be a huge influence in having these conversations and making sure that our patients' thoughts are really being brought to the front page. And so taking me to my question, what do you think institutions, and this is probably more directed to Kim here, institutions as a whole can do to make sure that not only the big question, the how do I want to die question necessarily, but that the day-to-day activities of patients are really focused on what that patient's goals are, what that individual's goals are. I feel like so many things have become routine in hospitals. You know, if you're on a ventilator, you get a chest x-ray every day to make sure that that tube is in place. If you are inpatient, I mean, routine AM blood draws are just part of the game. How do we let patients know that they have choices in the day-to-day management, and how do we empower nurses in that key bedside role to be influential in that place?
So that's about leadership, and you are all leaders. So one way to handle it is you regulate it, you make a policy. Policies are written down and often not easy to implement and practice. So I think it's about role modeling. It's about making sure that in work environments, in hospitals in particular, that you have conversations either at unit levels in staff meetings, in orientation groups. You have to make clear what the expectations are of the level of practice that you want to see. So making sure that we live our vision and that in whatever ways we can, patient-centeredness is made real. The way we start is by making sure that we're talking about it. So every day at a bedside, in care team rounds, in whatever venue we are able to have these conversations, the job of nurses is to make sure that they understand what the patient's goals are and that they are bringing that forward to the healthcare team. So it's a little bit of a patient at a time, a day at a time, but I think it's about leadership. So if leaders role model these expectations all the way through, if nurses use their leadership to exemplify these behaviors, then that's how we start. And a day at a time, a patient at a time, we change a system. But it's got to start with having conversations. So tomorrow, you can ask all of your patients, what do you want?
So I agree you are all leaders, and so I would give you all a charge. Patient-centered care is the new frontier. No one has figured this out. Mm-hmm. We know that we have a lot to do. You will be in leadership positions. We do know that whatever changes, whatever reforms happen within healthcare settings, they are going to have to improve health, care, and be sensitive to improving or maintaining cost. So you all have to look at the systems of care within you, where you work, and to put today's lens on it. We've given you some pretty powerful stories, and I'm hoping that you can see that there is an opportunity to have a better health outcome for people when they are more involved in their care, and the care is organized around their needs. There really is an opportunity here, but this is the new frontier, and you will be the ones who are going to be building it.
I think that this is a perfect note to close this conversation that I hope will be an ongoing one. I know that Amy and Kim would be happy to answer any additional questions. I'm sorry to those of you who we couldn't quite get to. Just in closing, I want to thank again Dean Haber and the NYU School of Nursing for hosting this event, your staff for putting this remarkable event together. Christine, thank you very much. Linda and the Hahn Advisory Committee, you guys have done a great job, and your leadership inspires. To all of you, the Hillman Scholars, really this event is about you. And we're very proud to play a small part in your education. And thank you all for coming. Thanks to all the representatives from the institutions who are part of the Hillman family. Janet, thank you for being here. Colleagues, Darlene, thank you for coming from the Jonas Center. For those of you not familiar with the work of the Jonas Center, I encourage you to visit their website. It's the Jonas Center for Nursing Excellence. And finally, Amy and Kim, this was such a wonderful event, and clearly we could go on much longer. And I hope that this is the beginning of a conversation that we engage in for a long time. Thank you so much.
Thank you.